Many women experience an array of symptoms as their hormones shift during the months or years leading up to menopause. Menopause is a point in time, but perimenopause is an extended transitional state. Perimenopause, tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc. Health information based on science, built on trust. I'm your Prairie Doc host, Dr. Kelly Evans-Hullinger, and tonight we will be talking about perimenopause and menopause. Perimenopause is the transitional phase leading up to menopause, typically beginning in a woman's 40s. During perimenopause, women may experience a variety of symptoms such as irregular menstrual cycles, hot flashes, mood swings, and changes in libido. These changes can be challenging to deal with as they can affect a woman's physical and emotional well-being. This period of a woman's life can be taxing. By talking with their medical professional, exploring treatment options, and connecting with others in the same situation, women can find ways to navigate this transitional phase. Tonight, we will discuss perimenopause through menopause and take viewer questions. Thank you for joining our discussion. This evening, we are joined in the studio on the campus of SDSU by Dr. Annette Siewert from Avera Medical Group, OBGYN Sioux Falls, and Dr. Emily Abele from Avera Medical Group Specialty Clinic in Brookings, South Dakota. Welcome, and thank you so much for joining us this evening. I was telling our pre-med group before the show how excited we are to get some OBGYNs in the studio. We don't get to do that very often, so we're really glad you're here. Can you tell us a little bit about yourself, Annie? Where are you from? And tell us about your practice a little bit.
Sure, yeah. So I'm originally from Yankton, South Dakota, and I did my medical school training at the University of South Dakota, and then I went to the University of Colorado in Denver for my residency training, and then directly to Sioux Falls for the last 12 years for OBGYN.
Yeah, and general OBGYN practice, obstetrics, gynecology, the full mix.
Yep, the whole breadth.
Yeah. Emily, how about you?
Yeah, I'm originally from Sioux Falls and went to USD for medical school and then down to Omaha at University of Nebraska Medical Center for residency, and then have been up here since then for the last 5 years.
Yeah, we're glad to have you. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about perimenopause through menopause. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So before we get to some viewer questions, I think these terms are things that people have heard about, but let's define them for the audience. I guess let's start with menopause. What is menopause, Annie?
Okay. Well, menopause is the easiest thing to define because that is defined as the period of time after which there has been 12 months of a woman's not having a period. So easy.
Yeah.
Black and white.
Right. But really retrospective. Like you don't necessarily know if you're in menopause in that first 2, 3, 6 months until you've gone 12 months is the definition. And then how about perimenopause? What are we referring to when we talk about that, Emily?
Yeah, so that's when we are going from our normal menstrual cycle and making that transition to actual menopause, where we've gone that 12 months without a menses. And so that can be that irregular cycle can have a lot of ups and downs hormonally as your body makes that transition. So that can be kind of the most uncertain period of time.
Sure. So how long does that usually last? What's a typical perimenopausal period?
It's very variable from woman to woman. there's different definitions of it. Some people say it's 2 to 3 years prior to the actual onset of menopause and a year after. But really, if you look at all the hormonal changes and the symptoms that women have, it can last 10 years, or it can start 10 years before the final menstrual period and last several years after. So, or kind of that transition period.
Yeah. And what causes menopause? Like, why does this happen, Emily?
Yeah, so we have a certain number of eggs that are in our ovaries, and over time we gradually release those, and we get to a point when there's really not a whole lot left, and our brain is telling our ovaries, hey, keep going, and our ovaries just aren't responding as much as they used to, and it's harder to recruit a follicle to be able to ovulate, and so the estrogen is going down because it's there's not as much tissue that's there that's making what the brain is asking it to, and so that decrease in estrogen is where a lot of those symptoms kind of come from.
Yeah, and tell us some of the most common symptoms that you see for people coming into your clinic.
I think
distressed about.
Obviously, menstrual irregularities, crazy periods, hot flashes, night sweats, hot flushes, night heat, decreased libido, changes in skin, weight gain, joint dryness. Yes, vaginal dryness, joint pain. There's numerous types of symptoms, but those are kind of the most classic, if you want to say that, as far as hallmarks of menopausal transition.
Yeah, good. And menopause is kind of an interesting topic, I think, because it's normal, right? Like, if you live long enough, you get to go through menopause, but it does cause quite a bit of suffering for some people. Like, when do we offer treatment for menopause? Should everybody get treatment for menopause? Like, what would you say to that question, Emily?
Yeah, so many people don't necessarily require anything. There are plenty of people who go through menopause and it's a breeze, and they're like, I can't talk to my friends about that.
Just keep it quiet.
Keep it quiet. But for sure, if it is at a point where it's really affecting your ability to do your daily life, if you are like, I just can't get through a day without like soaking through my clothes, or I am waking up multiple times at night just soaked, and I'm not getting good sleep with that, that definitely is a point that, okay, that is going to be a benefit, somebody who would benefit from therapy.
Yeah, good. Well, I think we're going to have a lot of questions, so let's just get to them. I think we'll hit a lot of topics as we do this. So we'll start with some questions that we got in from email. Let's see. Since transitioning to perimenopause, I get headaches for about 5 days before my period. Is there anything I can do to help with this each month? What did you tell that patient?
Sure.
Annie?
So as your hormone levels are changing when you are approaching menopause, it is very similar to, as far as what's happening inside your body, as puberty, almost like exactly the same. And so,
gosh, don't we all want to relive that?
Yes, no, but nobody talks about it. So it is a sense of hormonal chaos, and one of so during that time, right before someone gets their period, they're at a very low hormonal state, and so one thing that some people could consider doing is taking a low dose hormone or estrogen during that that window of time. That's a little. I mean, that would require obviously some nuanced care from your provider, but that's something that you could consider doing.
Okay. We kind of have a couple questions that are very similar. So before my period, we have an email from someone who experiences a lot of anxiety right before their period during perimenopause that seems to resolve when the period starts. And that we had to get another question. Each month before my period, I have days where I cannot sleep or wake up frequently. So these are like very similar kind of symptoms. So I mean, other options for patients like that?
Emily? Yeah. Sometimes you can can consider using, a lot of times even during our normal menstrual periods, we can have some of those symptoms, and we can use hormonal birth control to kind of regulate that. And that oftentimes can be really helpful in those periods of time as well. And oftentimes with some of the mood changes too, if there's underlying mood things too, you can also use antidepressants even during short windows of time. I've had some people who have benefited from just that short-term use and not necessarily having to do it all the way through the month if it's only for that amount of time that they experience those symptoms.
Yeah, so really personalized care, which is probably kind of a hallmark of going to be of our discussion tonight. I took a question on the radio show this week about, can you still get pregnant when you're in perimenopause? Like, how do you counsel patients about pregnancy through this period of their lives?
Although pregnancy is much less common, it definitely is a possibility.
Yeah.
So if you are still having relatively regular periods, then contraception is important if that's important to you. So yes, you can get pregnant, but it doesn't happen very often.
Got it. Okay, let's go to some more emails. Let's see. I have breast pain more than just PMS each month now that I'm in perimenopause. Seems to go away when my periods start. Is there something that can help with this? Another sort of pre-menstrual symptom?
A lot of times for just breast pain sorts of things, I don't necessarily have people do hormone sorts of things. Most certainly would think about using cold compresses, analgesics to kind of relieve some of that, and wearing a good supportive bra to be able to help with some of that can be helpful, but it's
kind
not
of symptomatic therapy.
Yeah, and there's some maybe evidence of caffeine contributing to that. So decreasing caffeine around those times of the month can sometimes be helpful. Not for everybody. But.
Yeah.
Vitamin E supplements can be helpful, as well as evening primrose oil.
Okay.
So that you can take it just during that time if you want, or take them all the time.
Okay, great. I'm just going to step back because we've talked a little bit, and there's a lot of discussion about estrogen and replacement of the hormone that you're losing, both in perimenopause, like you're talking about for symptoms, and certainly after menopause this comes up. This is a topic that I think there's a lot of confusion about, and rightfully so. I mean, when I was in training, we were really conservative about recommending hormone replacement therapy with menopause. Can you just allude to this pendulum shift and why, and what is the right thing to counsel patients about this?
So the pendulum is swifting. It's changing really swiftly right now, and hopefully for the better. In the course of my career was when the WHI study came out, which was a large study that was done in postmenopausal women looking at risk factors, and the primary goal of the study was to determine if estrogen would help decrease risk of cardiovascular disease. What they found actually in that study is that it increased risk of cardiovascular disease. So at that moment, there was probably between half of women were on hormone replacement therapy at that time. Right now, it's 5%. So once that study came out, it precipitously, or the use of hormone replacement therapy precipitously dropped.
Right.
So now what we're finding in post-analysis study is that the study was had a lot of flaws. It gave most of the women, or the majority of the women in the study, were over the age of 65, had not been on estrogen replacement therapy, and then they got estrogen replacement therapy and then had cardiovascular events. So there's some kind of hypothesis regarding the blood vessels that obviously is very complex, but what we know now is that if you start hormone therapy in the perimenopause, it has very, very few risks as far as cardiovascular disease, and there is lots of discussion in the menopause community that it could be cardioprotective, but most of the national menopause experts are not willing to say that everyone should be on hormone replacement therapy starting in perimenopause because of cardioprevention.
Yeah. There are some people that should not be on estrogen replacement therapy. Who are those very strict categories of people, Emily?
Anybody with known or suspected endometrial or breast cancer specifically, and then also any unknown vaginal bleeding from the uterus, because if we have endometrial hyperplasia or malignancy going on, then that can definitely make that worse. Also, people with active blood clots are a contraindication to that, and those with liver disease and stuff would be people that I would say, nope, you may not. There are other relative contraindications, but we definitely can walk through that individually with patients.
Yeah, very individualized. What would you add to that? Anything?
The other big one that I always screen for in my practice before starting hormone therapy is cardiovascular disease.
Sure.
But that's also very nuanced as well. So if you're at a risk of 5% or less over 10 years as far as your cardiovascular disease risk, like you're probably okay. If you're between 5 and 10%, you should only do a certain type of estrogen, and if you're greater than 10%, you probably should look for non-hormonal options.
Yeah. So very worthy of this should be a discussion with your provider who knows about your health history and can take all that into account. Sometimes the challenge is maybe not personal history, but family history. So things like a little harder to predict risk, family history of breast cancer and stuff like that. And then there's some preference that goes into it as well. Yeah. Okay, good. So we've summarized hormone replacement therapy, because I'm sure we'll have more questions about that. We did get a question about if I've already gone through menopause, it's been more than a year since my last period, and I start having vaginal bleeding again, what could cause that, and what should I do? What would you say, Emily?
Yeah, for sure would want you to be seen. That's the most important thing. Many times it can just be from atrophy, that tissue getting really thin, but it could also be polyps, hyperplasia, or precancers, as well as cancers of the inside of the uterus. And in a way, it's nice that we have a good window into, something's going on with bleeding. So when we get that symptom, it's really important to bring it up because it can be a lifesaver for you. Yeah,
I tell my patients, some people want to kind of write that off. I tell them we would never consider that normal if you're after menopause, right? Okay, good. Yeah, go see your doctor. Good. Let's talk a little bit about some of the sort of genitourinary symptoms that happen after menopause. So what happens to the vagina and surrounding tissue after we lose estrogen?
So estrogen deficiency, for lack of better words, causes a thinning of the vaginal tissue. And so oftentimes women report dryness and then, of course, painful intercourse, some bleeding that can occur, especially after intercourse or, any sort of trauma to that area, even just simple wiping after urination. It can be very uncomfortable, it can be very painful. Some women have, very significant atrophy or the thinness of the tissue and it is asymptomatic, but it can be very detrimental to someone's intimate life. So that's kind of the main thing that happens, but also it can lead to issues with incontinence and pelvic floor disorders. So there's a lot of things that can happen.
Yeah, I feel like I see it a lot in my older patients who they either have UTIs or urinary infections that happen recurrently, or they always come in thinking they have a UTI, and it's not a UTI, it's just pain with urination, but often it's that. How can we help people short of taking estrogen by mouth or systemically, Emily?
Yeah. So it's great that we have a bunch of different things that we can do. We can use vaginal moisturizers. So that'd be a non-hormonal option. And can also think about vaginal estrogen. And that's a much, much lower dose and really doesn't get a systemic dosage to when you use vaginal estrogen. So when we have patients who do need that, then that's a good option. There's a few other options for like vaginal testosterone, and there's I know I saw a study about a newer I don't even remember what it's called now, that can be helpful for patients. So.
Yeah. No, good options though. Yeah, don't suffer in silence with that stuff.
No.
Prairie Doc spoke with Molly Kuehl, a nurse practitioner at Sanford Health in Sioux Falls. Kuehl works with a population of women going through perimenopause and menopause and answers questions about what vitamins and supplements they might take while going through this transition.
truly there's not necessarily a lot of supplements that people have to be on. I think it's kind of a misconception.
Kuhl says vitamins and supplements generally do not have evidence behind them, but one that does is phytoestrogens. It can be found in items like soy, black cohosh, vitamin E, vitamin C, and even yams. The phytoestrogens in these items can help mitigate symptoms a woman may experience during perimenopause and menopause.
Estroven it's a brand name that's been around forever, and it kind of rolls in the black cohosh, the soy, vitamin E, vitamin C, and it's a really solid, relatively inexpensive supplement that women can take that can help, again, mitigate some of those symptoms that they may be experiencing, like the hot flashes, the night sweats, brain fog, things like that.
Kuhl says women in this stage of life can incorporate a few common vitamins and supplements into their everyday life.
We would say 1,800 international units of vitamin D and 800 milligrams of calcium daily. It's never a bad idea to take fish oil, and that dose can kind of vary on the person. The daily multivitamin, and usually with iron, as long as they don't have a problem with high ferritin or other blood abnormalities.
Estrogen has many positive effects on women's health. Kuhl says studies have shown estrogen given locally in the vagina can actually save women's lives by preventing urosepsis.
There are very protective benefits from estrogen. It can be cardioprotective for our heart. It can be protective for our bones. It can be very protective against urinary tract infections.
But when adding any new supplements or vitamins to your routine, Kuhl urges patients to talk to their doctor first, as they may cause side effects or interfere with other medications being taken.
Perimenopause and menopause are not a one-size-fits-all approach. It's very individualized per patient, absolutely.
I'm so glad that we did this, because I think there's a lot of stuff, any woman of the right age, if they're on social media, is probably getting these targeted ads about all this stuff that you can buy to help you with symptoms. And I think it's one of those places that people are really vulnerable because they want something to help them. And so I want to make sure people have good information. We had a question here, and I think maybe we can just take it into a bigger topic about someone who went in with some symptoms and had some hormone levels checked. She said, my estrogen was high, progesterone was low, and I don't know the situation of what symptoms she was having or what age she was at the time. But can you talk a little bit about hormone testing? Sometimes I have women come into my clinic and say, I would like my hormones tested, and I'm like, I am not really sure what you mean by that. Or sometimes I'll have people come in with 10 pages of lab work that they had done somewhere else, and I honestly have to say I don't always know how to interpret that, and I have a little bit of suspicion that the person that they saw may not also know how to interpret that. So I guess, Annie, my question is there a role for checking hormone levels? If so, what are those specific circumstances? And what do you tell people if they're in your clinic with a similar situation?
Well, I have patients coming in every day asking for their hormones to be checked. And what I tell them is that I don't necessarily need to check your hormones, because I'm going to treat you no matter what their hormones look like, depending on their symptoms. I think depending on age, if they're very young and they're having significant perimenopausal symptoms, I may check an FSH level, which can kind of tell us it's a crude measurement to see if you're kind of heading into the direction of menopause. But otherwise, I don't check hormones in my practice unless someone is currently on estrogen therapy, and I think they should be responding, and they're not. So, but really, that's just you don't even have to check at that point, because I can just switch routes, because it might be they might not absorb the estrogen the way they need to. So there's not a lot of reasons in my practice where I would specifically check hormones, unless I'm looking at treating hypoactive sexual desire disorder, and then I will look at a testosterone level.
Okay. Yeah, sometimes I see, testosterone levels and stuff, and I'm not an expert, but I'm not sure that a lot of people know how to interpret that. How do you respond to those conversations in your clinic, Emily?
Yeah.
They're challenging.
They are, yeah.
A lot of people think that more information is helpful, and I don't think it always is in this setting.
Yeah. And the labs can end up coming back very confusing. So even if they're having all of these symptoms, their labs might look fine. I had somebody come in today that was like, oh, I just had my hormones checked, and I'm so concerned about all these symptoms. And I was like, well, they look fine, but you are telling me that you're having these symptoms, and so I want to look at you yourself and make sure that we're doing the right thing for you.
Yeah. So maybe talk to your physician or whoever you see before, I assume those panels may cost a decent amount of money too.
And they really don't tell us anything, because your hormone levels can change throughout the day.
Right.
You can check, an estrogen tonight and then check it again in the morning or in the afternoon, and it could be different. And so it's not helpful as far as actually treating the patient.
Yeah, good information. We had a couple questions about in the setting of someone who's had a hysterectomy, so had their uterus removed and thus doesn't have a menstrual period for that reason. How does someone like that know if they're going through or have gone through menopause, Emily?
They might still have some of the other symptoms. So without the menses, you might still start experiencing some hot flashes or vaginal dryness or some of the mood swings. And it might initially be kind of a cyclic sort of situation and get more and more spread out depending on the patient. But
Yeah. And I guess it's important to differentiate if someone had a surgery when they're premenopausal. Most of those people just have their uterus removed, but if they had their ovaries removed, that's a different thing. What do we do for people who are younger and have to have their ovaries removed?
So surgical menopause is something that we have to be really cautious with, because if you have your ovaries removed less than age 45, that can actually have very detrimental effects lifelong, as far as like your cardiovascular risk, your bone health. So if someone, unless you're doing it for breast cancer, right. If we're removing ovaries, say, for endometriosis, then I would call it estrogen replacement therapy, where I'm actually supplementing them to where their levels should be at the time, if they're 37 or 42, because we need to protect their heart and their bones.
And then do you start to talk about withdrawing that at a normal menopausal age, or how do you approach that conversation later on?
Yeah, the recommendations is to stop trying to wean off of it around the natural age of menopause, which is 52.
Okay, great. Good information. So let's see. We have, so this is a call from a patient from Brandon. She had an early hysterectomy at 38. Doesn't specify whether she had ovaries removed, but never took hormones, and now at age 78 experiencing some fractures and bone issues. Could there be a connection, Emily?
Yeah, if she had her ovaries removed at the time of her hysterectomy, that most certainly can play a role in her fractures at this point. So,
Just exactly why Annie just mentioned that we should replace hormones if that's the case. Very common question. So we had an email question. I'm exercising just as much as I used to, but now that I'm in perimenopause, I'm gaining weight and not losing it. What can I do about this? Annie, what do you think? It's just like
this is all day, every day conversation. Personally, I get it. So, I think this is a very common problem. One of the issues is that weight gain is a natural part of aging, and so it's what's normal for menopause or what's normal for aging. So what I usually tell my patients, this is a comprehensive thing that we need to kind of attack on a multi-level basis, where obviously you need to exercise, but you probably have to exercise differently than you did when you were in your 20s or 30s. I think it's really important to obviously have your 150 minutes of aerobic activity every week, but strength training, whether it be weightlifting, Pilates, or you name it, needs to be a really important part of that, because there is the musculoskeletal syndrome of menopause, or sarcopenia, that occurs, and it's muscle wasting. And in order to protect your muscles and therefore your bones in the future, you have to build your muscle. Strong muscles also help with metabolism, so that helps a lot. So you have to start exercising differently, and you have to feed your body differently.
Yeah. And I mean, I feel like I have this conversation a lot, and I really try to coach people to just be kind to yourself. Like this, there are real changes. This is not, your own fault if you're gaining weight through this period of your life. And you might have to look at things a little differently than you did before, right? I mean, but it's hard. Aging is hard, and this is hard too. So. Question from email: how do you combat decreased libido during this time? They also mention, I'm up and down in my emotions every month. I find this super challenging, because I think this is something that, certainly there are hormones involved in libido, but it's so much more complicated than that too, right? With emotional health and relationship health and stuff like that. So how do you respond to that question?
I always start by talking through, okay, is there any pain that's occurring with intercourse? And making sure that if there is, then we're addressing that and helping them work through that, whether it's pelvic muscle spasms or if it's dryness, making sure that, okay, we're either sending you to pelvic floor physical therapy, or getting you vaginal moisturizers or vaginal estrogen to be able to make that more comfortable. But then very much emphasizing you still need to be falling in love with your partner, and making sure that that is a part of it, because our libido is so complex, and if there's a little thing that's rubbing you wrong, you may not want to be sexually active, because that is an instant turn off for your brain, whether you actually realize that or not. So making sure that they're focusing on being intentional about the relational part of that, in addition to making sure that physically we're addressing the things that I can help with.
Yeah. I feel like I saw an ad on television recently for a new pharmacologic treatment for libido with menopause. Is this something, am I recalling this wrong? Is there anything that you use specifically for this complaint, other than hormones at times?
Yeah, I think, first of all, it's so multi-layered. It's like a big onion that you have to start unpeeling. I think testosterone is a hormone that is indicated for the use of low libido in postmenopausal women, but it has a very specific indication, because studies have shown that it's only helpful in postmenopausal women who have low libido. We can potentially extrapolate that, but that's obviously very nuanced. There is DHEA, which is a hormone that can be converted to estrogen in the vagina, that can be helpful for sort of libido dryness. I'm trying to think of what you would have seen.
Yeah, that's all right.
That would have been new. Do you know?
Yeah.
Not necessarily a new one. Just I know there is a medication that's out there for libido generally, but it really doesn't increase the. I think the outcome was it increased sexual satisfaction with one in a month, and so for some people that is not enough to warrant taking like a daily medication for. So
that probably costs a lot of money.
Yeah.
Can the doctors talk about if hair loss is part of perimenopause, and is there something that we can use to prevent that? Annie?
So it can be, but that is also something that's pretty complicated. From an internal medicine standpoint too. But you can have some, mild hair thinning, some mild receding of the hairline. But usually, if that is occurring, there is something else happening. So iron levels can be low, as I think was mentioned in the roll-in. So that can contribute. Thyroid hormone can be abnormal. So there are, like, as far as hair loss, those are kind of usually other things besides estrogen, although estrogen can help because estrogen is a growth factor. So if someone starts estrogen, that can sometimes help with like hair health. But
got it. Okay. Let's see. Since entering perimenopause, when I get my period, it only hurts on my right side, and the pain stops when my period stops. Is that something that you could explain, Emily, or is that unusual?
I'm not sure I could specifically explain that right off without actually like seeing somebody and doing an exam and stuff, because there's a lot of nuanced things that can be kind of a part of that.
Yeah, good. Well, yearly exams with your OBGYN are important to monitor your health and changes as you age. Prairie Doc spoke with Dr. Brienne Mueller, an OBGYN physician at Sanford, Aberdeen, about the importance of exams even after menopause.
I always recommend a yearly exam for everybody because it's our way of taking a detailed history and really talking to people about where they're at and where they may be going, what risk factors they may have. And the way we figure that out is by having a conversation.
According to Mueller, the biggest part of the whole process is educating those who are going through the transition and getting screenings to know exactly what is happening.
So it's hard to like put a label like you need to have this or you need to have this on this year or every year, whatever. But if you meet every year and talk about it, then we can make a personalized plan for you that makes sense, that can really decrease your personal risk factors and hone in on exactly what's going to benefit you in the next year or the next 5 years.
Mammograms and pelvic exams are essential to women's health. They can help the doctor and patient connect during this time.
So it's important to know that annual exams that include a breast exam and a pelvic exam can really, really be helpful in, I can make connections sometimes with maybe things that the patient isn't making connections with.
These exams and screenings can benefit women by educating them on what to expect while also addressing specific risk factors.
All right, great information. We were talking about some estrogen-related topics, and we got a question here from someone who's been on estrogen and says, when should I stop it? So say, I guess, in theory, you start someone on estrogen for menopausal symptoms, they do well. When is it time to think about stopping estrogen? Emily?
Yeah. So from all of my training and everything that I've read, it seems like about 10 years is about when we should be working on weaning someone off once they've started, as long as they are past that age of menopause. So if they were like in their 20s and had their ovaries removed, no, that would be a different story. But someone who is getting it from a perimenopausal standpoint, that would definitely be a point to start weaning them down. And it doesn't need to be abrupt. It can be a wean down so that they don't have as many of the symptoms as they get rid of that.
Is that challenging in practice? Like, do you have a lot of women who struggle to come off estrogen later on in their 60s, 70s?
Or? I've had an 84-year-old woman, well, I think now she's 84, but she's like, if you take this estrogen away from me, like, I will die.
I've heard read about that before, too.
But actually, we know that being on hormones for 5 years is very safe. As long as there's no contraindications to starting. And then, between the 5 and 10 year mark, it's the risks maybe go up marginally, but still very safe. And most of the national experts say that there doesn't have to be a time where a woman has to come off, but you have to have a risk-benefit discussion because everyone's risk changes, all the time. And so if someone has a cardiac stent placed, in their 61, they probably need to have a discussion regarding. But it always should be a risk-benefit discussion with your provider.
Yeah. Individualized again. Good. We had a question about getting some irregularity of periods in perimenopause. So this person says they get their period twice a month for the last several months. And I've had a lot of patients who, I think this is a common reason that people come in. Everyone might have some symptoms, but people come in for either more frequent bleeding or much heavier bleeding. And that's probably a lot of what you guys see for menopause too. options do we offer for the perimenopausal patient who's just having excessive bleeding?
So depending on what sort of things that they would be candidates for, can definitely think about birth control, pills, patches, vaginal rings, our typical like contraceptive sorts of things. Can also think about Depo-Provera, can use progesterone IUDs is a pretty common one to be able to really reduce that irregular bleeding as well as the heaviness and crampiness of it. We also think about, especially if we've failed some of the medical treatments, thinking about an ablation of the endometrium can be an option. And if we've exhausted options, then we definitely think about hysterectomy at that point too. Other non-hormonal things that we think about, and some people don't necessarily think about it, is like ibuprofen leading up to a menstrual period can reduce the heaviness and the crampiness. It's not a miracle, but it definitely can reduce it a little bit. And we also have things like tranexamic acid that can also reduce the bleeding with our menses. So we have a few things in our tool belt to be able to address it depending on what people are candidates for and what their goals in treatment are.
Yeah, right. But that can really affect people's lives to suddenly have really heavy bleeding and try to get through their workday. And I had a patient in the last year who we needed to transfuse blood. She was sure she was just having much worse asthma symptoms, and no, her hemoglobin was 5. So, you know, that much bleeding may not be normal or tolerable for your body. Good. Let's see. We have an email. 49 years old, started taking Cariva Volnia. Is that a supplement anyone's heard of? A couple years ago for some heavy periods, which improved things, but now they're having some perimenopause symptoms. Oh, maybe it is a contraceptive brand name. Okay, so oral contraceptive. How will she know when to stop taking her birth control pill? This is a hard question to answer too.
This is a hard question. A birth control pill, especially specific, there are a few specific ones that are really great for the perimenopausal woman because they have a specific type of progesterone in them that can be helpful for hot flashes and night sweats. But I usually try and if they really want to stay on it, then I usually just keep them on until 50, 51, and see what happens if we go off it for a few months. Obviously, if their abnormal bleeding continues, then they should definitely have a workup with an ultrasound to see what else could be causing their abnormal bleeding if it hasn't already been done before. But I usually, if they're enjoying it and it's a good fit for them, I just continue it.
What's the difference between oral contraceptive, which contains estrogen, and the estrogen replacement that we might use for menopause? What's the difference, Emily? Yeah,
it's the dose. So the estrogen in hormone replacement is much lower than it is in a birth control pill. So definitely when we think about risks and stuff, it definitely is a lower risk of taking a hormone replacement level of estrogen compared to a birth control pill level.
And there's specifically different types of estrogen as well. So ethinyl estradiol is typically the one that is in the birth control pill, whereas estradiol or conjugated equine estradiol are the ones we typically use for hormone replacement therapy. So they're just a little bit different.
Okay, good. We had a telephone question from Rapid City just asking more about estrogen vaginal cream. How much does that get absorbed into the body? So I guess let's talk about that in general. So most vaginal estrogen products are a cream. How do we use that, and what do you counsel patients about as far as absorption?
So there's actually lots of different ways to take vaginal estrogen, not just a cream. Lots of my patients are like, I don't want that messy cream. It's messy. I don't like it. But there's a cream, there's a pill, there's a string. Those are probably the most common ways to give estrogen to the vaginal tissue. So there's lots of different ways to do it. And what was the second part of your question?
What do you tell them about absorption when it's like, how is this different than taking it by mouth?
Sure. So when we are inserting estrogen vaginally, it has very low systemic absorption, so there's very, very little detectable increase in estrogen in the bloodstream if we give it locally to the vaginal tissue. Whereas if you're taking an estrogen via pill or transdermal route, that's more of a systemic estrogen where we do see an increase in estrogen levels in the blood.
Yeah, so the vaginal estrogen really targeting those local symptoms and not necessarily the hot flushes and some of those other things. Okay. We had a related question, someone from Wessington Springs, older, 90 years old, and having some urinary issues, and was counseled that maybe a cream would help. She didn't know more information, but let's assume we're talking about vaginal estrogen cream. How does that help urinary symptoms, Emily?
Yeah. So the tissue for the vagina sits very close to the urinary system, and when we give vaginal estrogen, then that can improve the tissue quality inside the vagina, but it also improves the tissue quality inside the urethra and in the bladder, and so can make it healthier and able to deal with urinary infections a little bit easier, gets a little better blood flow, so our infection fighting cells can make it there and actually take care of things that it would otherwise take care of.
Yeah, good. We had an email question. I'm having this says hysteroscopy, but maybe hysterectomy next month. How does my body adjust to suddenly not having hormones? So I guess let's back up. What's a hysterectomy, and is this patient going to lose their hormones suddenly?
So a hysterectomy, by definition, is removal of the uterus and possibly the cervix, not necessarily removal of the ovaries.
Right.
Oophorectomy is where we remove the ovaries, where a hysteroscopy is where we can actually use a camera to go intravaginally to inside the uterus to take a look to see if there's something abnormal going on inside the uterus.
Yeah, and probably the vast majority of hysterectomies that you do not involve removal of the ovaries. Am I correct in that assumption?
As long as they're in the age range that is less than 50, then I leave them alone unless I have a good reason to take them out. If I have a super abnormal ovary, yes, let's get that one out. But otherwise, we leave those alone. We do take the fallopian tubes out, though, to help reduce our risk of serous ovarian cancer that can originate from the fallopian tubes.
And I see a lot of elderly patients. Sometimes it's really murky. They had a hysterectomy 50 years ago, and I'm not sure really what organs are left in their pelvis or not. But I get the impression that decades ago, ovaries got removed quite more liberally. Is that true?
Yes.
Yeah.
Yes.
Okay. We try not to do that if it's not necessary anymore. Good. We had a Facebook question. Why did I never hear the word perimenopause until the last few years? I mean, it's a term it's not a new term.
Yeah.
Maybe that just means more public education. I mean, what do you think?
I think it is, people are becoming more educated.
Yeah.
There's obviously a lot of social media influencers that are really shining a very bright light onto menopause and the perimenopausal transition, which is wonderful. There's a lot of research dollars now being kind of funneled towards women's health, which is amazing. So I just think that perimenopause, menopause is kind of having a little bit of a moment. So, which is good.
Yeah.
Which is good.
Just out there more. Yeah. Good.
I think there's a lot of patients who are older that they grew up with, like, you just don't talk about it, and now it's becoming okay to talk about it, and we welcome that, to be able to make sure that we're taking care of people, because I think there's plenty of people who really suffered through that and really could have benefited from having that taken care of.
Yeah. Yes. We've talked a lot about hormone therapy. We sometimes see patients who really are in for the hot flushes or vasomotor symptoms, or waking up a lot at night with sweats. Do we have anything besides hormones that can help patients with those symptoms?
Yes, there's lots of different non-hormonal options for the treatment, especially for patients who are not good candidates for hormone therapy. A common one are antidepressants, which are they work on the same pathway in the brain that kind of contributes to hot flashes and night sweats. So they can be very effective in treatment of those symptoms, especially in those patients who are also having some of the more common mood symptoms like irritability, rage. So that's probably the most commonly used medication currently, but there's a new medication that has a brand name Veoza on the market that has a kind of a really cool novel mechanism where it's a JAK kinase inhibitor, but which is also the neural pathway in the brain that causes hot flashes and night sweats that is very effective and has not a lot of side effects. So that's a new one, and there's a new one kind of coming down the pike, which is in the final stages of being approved by the FDA, kind of along those same lines. Gabapentin is something I use at night in lower doses, especially for women who just have night sweats who are having difficulty sleeping. I'm trying to think of, those are kind of my big three.
Yeah, those are the major ones that I usually think
Maybe
through.
that's what I saw on television. I wonder if that's being advertised on television. We'll probably start getting more questions in clinic about it.
Yeah.
Probably.
Yeah, good. Let's see. Can perimenopause cause GI symptoms? We had an email question. Do you ever see that, Emily?
There's a whole gamut of people, things that people come in with, but that's not necessarily a typical one that I see.
Yeah.
So
Maybe a coincidence.
It might be more coincidental.
Okay.
But I've learned that any symptom can be
enough.
possible.
Fair enough. Another email question. Can we talk about what causes brain fog during perimenopause? What do you hear patients tell you, and is there something we can do to help with that stuff?
So brain fog is actually a really common complaint that I hear from my patients, and it's actually probably one of the most disturbing ones because you have, potentially a woman who is in a high, at the peak of her career, and then all of a sudden feels like she can't, trudge through her day because of her, she just feels almost incapacitated mentally. So it's a very common symptom, and it's due to, there's a lot of study going on, but somehow it's due to the estrogen decline in the cells in the brain and how they're responding to them. So it is a very real thing. It can be helped with a few things, but estrogen can definitely help it.
Yeah. Good to know. And it's just such a crucial time in a professional life, and probably a lot of women are balancing a lot of demands at that stage in their life, so that can be challenging. Let's see, we've got just another minute or so left. We had a phone question about uterine prolapse. Is it common? Not necessarily a menopausal symptom, but certainly something that happens commonly at a later stage in life. What do you do for uterine prolapse in a minute, Emily?
So it depends on how far it has prolapsed and what exactly your goals are, but pelvic floor physical therapy can be really helpful using a pessary as a silicone ring that can sit inside the vagina and hold up the things that are falling down, and there are surgeries that can help with that as well.
Just there's a lot of variation in the severity of that, but good. Well, I think we got a lot of questions. It highlighted how much our approach to this has changed, and hopefully adding to just being out there with good information about menopause, and so we really appreciate the time here. Our winner tonight is Shelby. A book will be sent to you shortly. We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Thank you to our guests, Dr. Abele and Dr. Siewert, for volunteering their time to help us learn more about perimenopause through menopause. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
oral health is a key indicator of overall health. Preventive care can help stem the progression of oral and gum diseases and help to lessen the risks associated with heart disease, diabetes, and pregnancy. The importance of good oral health next time on Call with the Prairie Doc.
My name is Jennifer May, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,